Dear colleagues, my name is Yongdae Kwon, coming from Department of Oral and Maxillofacial Surgery, Kyunghee University, Seoul, Korea. It's my big pleasure to give a talk in this prestigious program. Today my topic is soft tissue quality and skeletal surgery for obstructive sleep apnea patients. So let's get started. In the disease-making process of OSA treatment, anatomic and physiologic factors should be considered at the same time. In surgical approach, phenotype-based approach prevails because surgery is anatomically directed to the level of obstruction. Anatomical factors associated with OSA are obesity and craniofacial deformity, including these things like inferior position of a hyoid, retrognathia, and so on. Physiologic or functional side of OSA would be a difficult part of to be taken into account when a surgical plan is set. Genioglossus is a key muscle for airway regaining, and this muscle is thought to be highly reactive to chemical drive. So, when airway compromised, that may lead to breathing disorder happens, this dilator will be activated and open up the airway. Arousal threshold is often addressed when we talk about the etiology of severe OSA. A patient who presents a higher threshold is more prone to hypoxia because of a prolonged apnea. So in severe OSA patient, some sort of the physiologic defect or functional problem can be behind the anatomy. Two anatomical things that can limit the airway dimension. One is soft tissue and the other is ball. One is like a box here to contain something. Soft tissue is like a bubble wrap inside the box like this. So too much bubble wrap would limit the space that you can use. Depending on the phenotype, you can go for a surgery. So if you want to get rid of some bubble wrap inside the box, then you can go for a soft tissue surgery. Otherwise, you can go for a skeletal surgery, which is expanding your box. Let me talk about briefly outcome predictor of MMA. What is the most reliable predictor of MMA outcome? The amount of maxillary advance would be 1, but we really don't know how much advance would work. According to this paper, the higher AHA values the patient present, the higher chance of improvement can be expected after MMA. For example, you can have when you have a severe OSA case, then you can expect a huge reduction of AHI. But large amount reduction of AHI may not be a success for a severe case. For example, you have a preoperative AHI 90 in your patient, and the postoperative value was around 40. Then the result may not be a success, although patient OSA symptom can be relieved in certain degree. So another treatment measure would be necessary in the future for the patient. The amount of bimaxillary advancement is highly correlated with the airway volume change, as arithmetic prediction of volume increase is possible when an MMA is done. However, the increased airway does not always mean a success. So that's a problem. So if you have a patient whose preoperative AHI is more than 90, then you have a really great reduction of a preoperative AHI. The postoperative AHI will be like 40. Then you still have really great reduction from the surgery, but according to the success criteria, is not that successful at all. This young patient was transferred for MMA. Some conservative treatment sessions were not that successful. His deficient chin led us plan on a rotation MMA. This is young patient. Actually, CPAP was rejected from the patient, and the choice was MMA. So this guy has a prominent nose. The chin was a little bit deficient and not that obese. So I think this is a right case for the bimaxillary advancement. Pre-op and post-op CBCT scans here, airway regaining was really significant. You can see the really great regaining of the airway from this CT scan. So this is a pre-op and 2 years post-operative clinical photo of the patient. The profile change was satisfactory. Looking at the 2-year post-operative PSG, the reduction of preoperative AHI was more than 50%, which is good. And the obstructive pattern changed into hypopnea dominant pattern, which is also good. Slow wave sleep increased quite a lot. But when I saw the post-operative CBCT scan, which shows a really huge regaining of the airway volume, the post-operative AIG value should have been better, but the reality was something different from what I expected. So I had to think about what lies beneath the airway volume change. Looking at the success and cure in USA, surgical success can be defined as 50% reduction in preoperative AHI with post-operative treatment of AHI of 20. When it comes to cure, it's much more difficult to attain. The post-operative AHI should be around 5. Let's move on the airway muscles. Genioglossus and tensor are known as airway dilators. Most of skeletal surgery is involving genioglossus because this muscle can pull the tongue and the muscle is a major airway dilator. So even if we are working on OSA patient based on phenotype-based approach, functional study would be good to be investigated. Let's give a look to one electrophysiological study. According to this study, genioglossus recruitment can allow adequate ventilation, while tensor does not appear to contribute to the breathing stability error. So, according to this study, genioglossus is a really important muscle in airway regaining. Let's give a look to this case. So this gentleman came to me complaining of a severe OSA. So according to preoperative values of AHI, which is more than 75, he was in severe OSA. This guy was a really severe OSA patient. So he's obese. His BMI was more than 29, and he has a thick neck and narrow airway. So treatment option can be like this, so CPAP, MMA, and any other phase 1 surgery. But the patient didn't like the MMA at all because he is more than 50. So in that age, usually patients don't like the surgery like this. And the CPAP was also rejected because he travels quite a lot. So he was not able to carry his CPAP machine in his travel. So phase 1 surgery was recommended for the patient. So we did palatal flap and nasal some surgery, and genioglossus advancement was done. So this is a virtual osteotomy for the patient. We were able to get this CT scans of the patient, and we were able to easily visualize the location of genial tubercle in the backside of the mandible like this. So this is a virtual osteotomy of the patient. This is a 3D printing surgical guide for the patient. This kind of things can be fabricated individually using CBC scan, and you can see the attaching genioglossus muscle on the back side of the genial segment of the patient on your right hand side. So it may reduce any chance of missing the muscle attachment on your genial segment. So this pre and post-operative radiograph, and look at the airway, which has been widened quite a lot. For this specific patient, the changed facial profile was favorable because his chin was deficient. So the facial change was acceptable for the patient, and we were able to get regaining of the airway looking at this pre and post-operative changes. Comparing pre and post-operative CBCT scans, which show the change of the airway volume, you may notice that there is a really huge increase of the airway volume, especially at the level of retroglossal area because we did a genioglossus advancement. But there is still some narrow part of the airway post-operatively at the level of retropalatal area. So maybe this would be one setback in this specific case. But unlike the airway regaining, which was observed in the CBT scan, the post-operative PSG showed really disappointing result. The patient was still symptomatic. That's the problem. Why this is happening? As you know, a skeletal surgery is an irreversible treatment. This was really painful for me. So we did the surgery, which is irreversible, but the patient still was suffering from this kind of OSA symptoms. Even though we can rid of anatomical obstruction, functional parameters or other affecting factors may override. Patient age, neuromuscular function, BMI, and fatty tongue. These may be factors affecting the outcome of the OSA surgery. Let's talk about the workout for the tongue. According to this paper, the tongue consists of mainly muscle, but fatty infiltration is seen, and relatively higher fat was seen in the posterior tongue area. This feature might have something to do with OSA, I think. This is a kind of an autopsy study. So tongue is a really small organ, but the fatty infiltration is really differential. The higher BMI, the more fat in the tongue. Actually, tongue has a higher fat percentage than sternocleidomastoid mastoid muscle has. So maybe an obese patient may have a lazy tongue, I think. But the limitation of this study was OSA was not considered in this study because this is an autopsy study, so we really don't know why these people just died. There is some MRI study for the OSA patient. According to this MRI study, OSA patients often show higher fat in the tongue compared with normal subjects with the same BMI. That's a really interesting part of the study. So there is a two guys whose BMIs are the same. But in amniotic patient, the fatty infiltration would be much severe. So we can say OSA patient have a lazy tongue, I think. The fatty infiltration is significant in lower retroglossal region. And this may tell you that some retroglossal part can just fall back to the pharyngeal wall, which may lead to airway obstruction. Taking an MRI for every OSA patient is actually impossible because of the regulation of National Health Insurance System. I think we may evaluate tongue and genioglossus using CT scans. Hounsfield unit can be measured, and based on this report published in 2014, the Hounsfield unit of a sound muscle should be around at least more than 30. If the Hounsfield unit value is less than that, the muscle seems kind of fatty. These are CT scan images of the gentleman who got genioglossus advancement. I just presented the case right before. The mean value of a Hounsfield unit at the retroglossal area is like this. So you can check the Hounsfield unit of this area. The mean value was around 17, and mean value around this area on your right hand side was around 35, which is quite low. And these Hounsfield unit values from normal subject without OSA symptom, the values were quite higher than those from the amneic patient. I'm not telling you right now that you can check Hounsfield unit in the tongue area to predict treatment outcome of a OSA patient. But simply this would be a motivation for me to investigate this topic in depth. Maybe I can come back to you when I'm done with more substantial knowledge about this topic. So anyhow, comparing amneic and normal patient, you can check the significantly lower Hounsfield unit value in the genioglossus and tongue area. Using another software, I was able to check the Hounsfield unit of a patient. So in this amneic patient, the average value of Hounsfield unit was around 23 and 35, which is quite low. And in this normal patient, the average value of Hounsfield unit in retroglossal area was more than 57, and other areas showed the value of more than 67. Just back to the patient. So looking at pre and post-operative CBC scans, airway regaining was really significant. So I'm just telling you that the patient who got MMA in my presentation, so there was a really huge airway increase, but the actual outcome was not that satisfactory, like I said. The patient was okay, but so yeah. I think there must be something behind the airway volume. So that might be a soft tissue quality around the airway. So looking at this patient, so the value of the Hounsfield unit in the retroglossal area was less than 20. So it might be one region. So petty infiltration might be one region of poor outcome if you did a back surgery. So there was some study about weight loss and upper airway anatomy. So this may be a part of the importance of tongue fat. Tongue fat is increasing in obese patients with OSA, and this may tell you the relationship between obesity and OSA. I know that weight loss can improve OSA, but we really don't know what is the mechanism behind that. Strong positive correlation were observed between tongue fat change and both measures, which are weight change ratio and AHI change ratio, suggesting that percentage change in tongue fat was the primary upper airway mediator between weight loss and AHI reduction. Lifestyle modification can help to work out the tongue, so we always ask our patient to work out. And this is another study about the respiratory movement of the tongue in OSA patient, but this study was done in wakefulness status. So these images are telling you that some compartment of the study, dilatation fat patterns were classified based on the maximum anterior-posterior movement during inspiration. So, like on your left-hand side, the category of the movement was like this. And just looking at the result of the study, people with more severe OSA had larger movement and moved more compartment. In order to maintain airway patency, I think OSA patient would need more effort to maintain the airway patency. So the more muscle should be deployed in order to maintain the airway, and the more movement would be necessary. In the meanwhile, people without OSA moved only one compartment. So people without OSA would need less effort in order to maintain OSA. That's the difference between the two groups, I think. When a definitive and irreversible treatment like MMA fails to reach the goal, a functional approach like hypoglossal lobe stimulation may salvage your failure cases. This technique is not yet available in Korea, but I think this would be a good rescue option for a failure case or recurrence. Along with the phenotype-based approach, functional surgery like this would be beneficial to OSA patient who had undergone some kind of irreversible surgery like MMA. Let me recap my talk here. So this is the conclusion of my talk here. Surgery is a phenotype-based approach. Preoperative AHI and measuring advancement seemed outcome predictors for MMA, according to some MMA study. Skeletal surgery can surely achieve airway volume increase, but AHI reduction may vary depending on the individual case. Genioglossus is an airway dilator, and fat distribution in the tongue showed higher in the posterior region. OSA patients may present more fat in the tongue, especially in the lower retroglossal region. Muscle quality of the tongue and genioglossus would be an affecting factor for OSA treatment outcome. Lower genioglossus compartments should be deployed to gain airway patency in OSA patients, and this may mean OSA patients would need more effort in order to maintain airway patency, while normal patients would not need that much effort in order to maintain airway patency. Functional therapy, including myofunctional therapy and hypoglossal nerve stimulation, can be considered along with skeletal surgery. OMS surgeons should pay attention to soft tissue quality and neurophysiological aspect. Therefore, further evaluation measures should be sought, and we would need active communication with our patients who are suffering from OSA, because back surgery is one option. It's not almighty at all. Thank you for your kind attention.